Good afternoon and welcome to the Deuk Spine Institute's live broadcast of spine surgery. It is now June 27, 2023. This is our last surgery of the day. This young lady presents to us from Texas. She's got two bad discs in her lower back, number L4-5 and L5-S1. She has had surgery in the past. She had a microdiscectomy. You can see the scar here. So we are going to be working on L4-5 and L5-S1. Now she's got back pain that goes down into her left leg. So clearly the back pain comes from the annular tear, and the leg symptoms come from the nerves that go down her leg and go past the tear where the herniations are. All right. We've already placed one needle while we were getting our broadcast going, and that was at L5-S1. We're now going to put a little bit of numbing medicine, and then we're going to make a small incision, 7 millimeters, and that will be the size of the incision we make for the whole surgery. We'll place our second needle at L4-5 because we're fixing two discs today in this young lady. The procedure is called the Deuk laser disc repair, and Deuk laser disc repair is a type of endoscopic spine surgery done here at Deuk Spine, pioneered here at Deuk Spine. You can see the needle there is headed right for the L4-5 disc, so it's perfect trajectory. Shot. All right, how is she doing? Shot.
You having any pain in your legs?
AP.
You okay?
You just lay still. We're waking you up so we can ask you some questions.
You have any pain in your legs?
All right, so she's been asleep, and now that we're getting close to the disc and the nerves coming off the spine, we need her awake. One of the ways that I gauge if I'm putting my needle in the right spot, and also to be able to do a discogram and get her feedback, is I need her awake helping me in this surgery. So she will help. Shot? Yeah.
Are you having any pain in your legs? You into your leg or your back? Where is it? Huh?
We're nowhere near the nerve, so. Your back? Is that your back? So I hear her, she's going, as I'm touching your disc. That's one of your bad discs. We're going to fix that for you today, okay? All right, we're going to put you to sleep in a minute, but I need your help first, okay? All right, I'm going to let you relax for a minute. Just take 3 deep breaths. We'll do a count. 1, good. 2, good. And one more. 3. Beautiful. All right. I'm going to put you to sleep in a minute, but I need your help first. All right, folks. So we've got a needle in each disc. It's through the foramen. It's perfect. I need to find out if these are the source of her back pain. Can you hear me? Are you having any pain right now? What'd she say? I can't hear her.
What did you say? You having any pain right now? When you press on the needle.
Yeah, I'm not touching anything. Are you having any pain right now?
No.
All right. How bad is that on a scale of 1 to 10?
Give us a number. 8.
What's the highest it goes? Yeah, that right there. What's the highest it went?
Number.
No, what did it go to when I just did that? What was the highest it went to? All right. All right, so it was 8/10 was her highest. So L4-5, she's got a small tear. Can you show us the tear, Monica, on the x-ray? Go to the x-ray, Henry. It's right above the needle. Just to the right. 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 Monica, listen to my hand. Listen to my voice. To the right.
Patient recovery is doing well.
Move the arrow to the right. Your other right, Monica. That is to the right. That's where I want you to go. Jesus Christ. Now a little bit to the left. You see that little wisp of dye right there? That's the tear. Woo-wee! You're doing great. It's not you I'm having struggles with. You just lay still. You're doing fantastic. Monica is testing my right and left. All right. Is that better? Mm-hmm. How bad is that on a scale of 1 to 10? Huh? What? How high? 8. That's the highest it went? All right. All right. Is that where you get your back pain? Yeah. You can hear her, I think, right, Henry?
Yes, we can. A little bit.
You're doing great. We just tested both discs that we're going to fix, and they're both painful at 8 out of 10. You're doing great. We're going to fix that, so when you wake up, that pain will be gone. Right now, I need you to count from 1 to 100 out loud in Latin. All right, how about Dutch, since you speak Dutch? Let's do Dutch. Nice and loud. All right. Very good. Keep going. You're doing great. So as she's counting, we're putting her to sleep. And I don't speak Dutch. As she goes to sleep, she'll stop counting, right? So I know when she's asleep, when she stops counting. Keep going. You're doing great. That's a herniation. Dye. Yeah, dye in a herniation right there at the bottom of the disc. All right, so she's asleep at this point. Shot. I'm going to take this needle out at L4-S1, leave the L4-5 needle in there, and shot. I want to make sure I'm not taking my guide wire out. You want to leave the guide wire because it's there to guide the dilator. That's the whole purpose of a guide wire. So here we come with our dilator. Dilator is tapered at the tip and shot. As I go in, I'm going to give her some numbing medicine just to help, ease any pain or discomfort she might have during the procedure. The numbing medicine is injected into the dilator and it comes out the tip. So she's doing fantastic. She's asleep now. Our anesthesiologist has her completely out with propofol. But her airway is secure. She's moving oxygen well. All right, a little more numbing medicine. Once I place the dilator, I'm going to then bring in the tube that we're going to do the surgery. It's called a tubular retractor, and its diameter is 7 millimeters. You're going to see that in a minute. It is super small. Shot. As I look up and I advance, you've got to take shots. I don't want to stop my dialogue and talk to you, Monica. All right? Now, we're going to have to drive down the dilator, and now you can see the tip of it at the back of the L4-S1 disc, and I feel it going in. I want to bring this dilator into the disc. Now, this technique was something developed by Dr. Anthony Young. It's called the inside-out technique, and you start inside the disc where it's safe. Some surgeons do transforaminal endoscopic lumbar surgery starting outside in the foramen. And I think that that's a dangerous way to do it. There's a higher chance of injuring the nerve. And we don't want to injure the nerve. We want to just fix the disc. That's good. So we are now inside the disc with the tube. Luis is going to, I just touched here. I'm just going to change my glove just to be safe. I need a new outer. All right, take a shot. You can see we are inside the disc with the tube. So I'm through the annular tear, and I'm inside the innermost part of the annular tear where the herniation starts. How's our blood pressure? It's left. Good. All right, if you have questions, feel free to ask. But right now, I'm going to have Henry run a video that shows why do herniated discs cause so much pain. At Deuk Spine Institute, we discovered the reason. It is inflammation within the annular tear. Everything okay?
Yeah. Just
All right, let's go down the rabbit's hole, into the tube and down, and we're gonna
We need the TV on, please.
we're going to use our endoscope. Can you see this, Henry?
Yes, we can.
All right, so this is the endoscope. It's long. It's about 14 inches long. It's connected to irrigation so we can clean out the blood and pieces of disc herniation. It's got a light source here, which needs to be turned on. And this is a fiber optic light source, by the way. And then we've got a camera so we could see through the endoscope. And we've got a laser fiber, which we're going to bring in a moment. And that laser fiber is how we're going to repair this disc. All right, here we are inside the disc, a lot of scar tissue. Now remember, we're not using the blue dye today. This is the L4-S1. Look at that disc. It's really frayed. And this is not normal. This is not what a normal disc looks like. This is a damaged disc, and this is why she's having so much pain. This injury looks old to me, at least 20, maybe even longer, 20 years old. And there's the laser. Now the diameter of the laser is 1 millimeter. Is that correct, Luis?
Yes, sir.
So the blue stuff is a plastic coating, and the glass fiber you're seeing is a pretty standard fiber optic cable. You all know how the internet gets across from one continent to another. Of course, if it's Elon Musk, it would be through Starlink, which is a satellite program, but the rest of us, the rest of the world uses fiber optic cables. Fiber optic cables use high quality glass fibers that transmit light, and the light basically dances, pulses, and it sends signals, data. Data is encoded within those light impulses. And when I say light, I don't mean the type of visible light that we're used to seeing. I'm talking about usually laser light. So we're using lasers and fiber optic cables for a different reason, to repair the disc in this patient with a bad disc. All right, so we're at the bottom of the tear. I'm starting to move up the tear, and you can see already this is all herniation. This is exactly what's causing her pain. Hey, have you started the video yet?
Not yet, no.
Let's go ahead and start that video so
Okay.
people can understand.
Copy that.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, welcome back. And we're still working on the L4-S1 disc. Everything is going well. I'm going to bring the laser back in. I just used the grabbers called pituitary rongeurs to remove about 5 or 6 pieces of herniated disc. Thank you, Oscar. Good job. You can see the end plate to the right there. that surface that's smooth. It's not really smooth, it should be smooth, but it's kind of irregular, but it's smoother than what you're seeing here, which is the herniated disc. So, end plate is bone. It's really the surface of the vertebral body. You can see a left and a right. And as we work our way to the back of this L4-S1 disc, where the nerves are, you're going to see the vertebral bodies come closer together.
We have a comment. This comes from Nick on Facebook.
Yes.
Nick has said, "Congratulations for your amazing work. I will say it again and again. You are the best."
Nick, thank you so much. I appreciate it. And I honestly could not be here without my team. They make me look good. They make my job easy, honestly. But thank you. We have 70 employees at Deuk Spine, and I just had a meeting yesterday with all of them, all staff meeting, and we do that every quarter. I do a town hall style so we can ask questions, make comments, talk about things. We also provide our quarterly awards to our staff who have stood out every quarter, and we have, how many superheroes? 6 superheroes now? Huh? 6, right? We have the Hulk and Wonder Woman and Ant-Man. And basically each of these awards that we hand out, the employee who gets the award gets to keep it at their desk for 3 months, right? Yep. 3 months. And then I've never gotten one, but you know, like Ant-Man, for example. What's the Ant-Man? Like small, like a role that nobody really knows about, kind of like in the companies, you know, someone who's working behind the scenes, but it's a very important role. So that's our Ant-Man award. Anyway, yeah, like I said, I know that this video that you're watching, these surgeries, they are our public face of our company, but the reality is that there's a lot of people that make up Deuk Spine and make us work behind the scenes, and they make my job easier. I wouldn't say easy, I guess that's a bit of a stretch, but yeah, thank you. Thank you very much. Okay, so at this point, a lot of scar tissue. You see that? White stuff? That's from her prior surgery, and the scar tissue isn't so much the problem, it's the herniated disc that causes the scar tissue. And I want to make sure I've gotten it all out. Now people say to me sometimes, "Dr. Deuk, will my MRI look normal after your surgery?" The answer is no, never. Your MRI is never going to look normal again. Because once you damage your spine, it's always going to look abnormal in your MRI. But the point is that MRIs do not tell us what's wrong. Patients do. And I keep saying that over and over again because so many doctors and so many patients, we have this culture of believing that the MRI will tell you what's wrong, but it doesn't. You see, the most common reason people go and get an MRI is pain, whether it's back pain or leg pain. And MRIs don't show you where pain comes from. They really don't. I mean, if they did, I'd tell you. If you gave me an MRI with a couple of herniated discs and said, all right, here's an MRI with a couple of herniated discs, does this patient have pain from those herniated discs? I would not be able to tell you. First thing I would do is I would call up the patient and say, hey, do you have back pain? And there's a damn good chance their answer is going to be no, I don't have any pain. And that's because most patients with herniated discs don't have symptoms. Only a few do. So that's why we don't get MRIs on everybody looking for herniated discs. We only get them on people that have symptoms and need treatment. And by the way, you don't need treatment if you don't have symptoms. So if you took all the people walking around on the streets with, just took people over the age of 40, and you get an MRI of them, of their back, you're going to see that they have herniated discs 90% of the time. However, they don't have symptoms. And that's because most people with herniated discs don't have symptoms. So the fact that somebody has a herniated disc is not a reason to treat them. They have to have symptoms from the herniated disc. And that's rare. That's why I say MRIs don't tell you what's wrong, patients do. And it's a very important point to remember. All right, there's some fat right here in the epidural space, right outside the back of the herniation. I'm trying to get a little bit more medial.
Sensitive part of the disc.
We
Yeah,
have-
this is the most sensitive part of the disc.
I like the rough with it, but I'll put it.
Sorry?
I like the rough with it, but I'll put it.
Yeah, whatever you want to do, just keep her safe. Yes, Henry?
We have a question.
Yeah.
This comes from Sammy on YouTube.
Hi, Sam.
They asked,
Grab
I
her.
am new to your channel. I had 4 back surgeries between L4-5 and L5-S1,
I'm sorry to hear that.
ended having it infused and left drop foot with this surgery.
Yeah,
Uh,
sorry to hear that.
You were doing with what? And infused it and left drop foot surgery with this. You doing with are the risk that the patient will end up with a drop foot?
Yeah.
Oh yeah. What are the risks that the patient will end up with a drop foot? Is what I believe what they're asking.
Yeah, Sam, thank you. So, Sam, great question. The risk of a drop foot depends on 2 things, the surgery you're doing and the qualifications of the surgeon, basically how good the surgeon is. So this surgery, like any spine surgery in the lumbar spine, could give you a drop foot. I think it's less likely to do so than open surgery like microdiscectomy, but it's not zero. And if I had this surgery being done by a doctor who didn't know what they were doing, then the risk of drop foot would be high. I mean, almost 100%. So as long as the surgeon is good and they do this particular surgery, the risk of a drop foot is very low. It's less than 1 in 500 for me. Now that said, sometimes we've never had a patient with a drop foot from the surgery. That's because I'm very careful with the nerves. But other surgeons do have drop foot after surgery. That's because they're not careful. They don't know what they're doing. The key is to know where the nerve is and to make sure that you respect it and don't damage it. You leave it alone. Okay? Like right here is fat, the yellow stuff. The red stuff are blood vessels. There's some bone spur here. But we don't just have a herniated disc here. We've got scar tissue, a lot of it. And we've got herniated disc and bone spurs. So we've got a variety of things going on down here. And what I want to make sure is I get rid of enough of the disc herniation, enough of the scar tissue, and enough of the bone spurs so that I get the pressure off the nerve and that her leg pain goes away. So does that mean you need to get 100% of the herniation or 100% of the bone spur? Absolutely not. And if you're a surgeon who tries to get 100%, you are going to fail every single time because it's impossible to get 100%. No surgeon alive can do that. No surgeon. How do I know? Because I'm quite literally one of the best in the world, and I can't get 100%. I would never tell you I would do 100 because it's not humanly possible. Okay? So, we're always going to end up leaving as surgeons some herniated disc, some stenosis, some scar tissue, some bone spur. It's not possible to get it all. And if you try, you're going to hurt the patient, because trying to get all that means you're going to be pushing on things, cutting things you shouldn't be. And that's going to cause complications. And you have to know when to stop. That's one of the things that a good surgeon knows, is where to stay away from and when to stop, okay? Like I've done a lot here. I've probably gotten rid of 60%, 60% of her herniation at 5-1. 5-1 is very hard to do because of its angle of approach, because of the iliac crest, because of the facet joints enlargement, because of the anatomy that's the widest facet. So there's a lot of reasons why this is the toughest, to get to. And a lot of surgeons that do lumbar endoscopic, they don't do 5-1 transforaminal. They won't. I don't know anybody that does 5-1 transforaminal besides me. And it takes a very highly skilled surgeon to do 5-1, which is where we are right now, L4-S1. A lot of them will do endoscopic translaminar, which is bad for you because they're removing ligament and bone. And I don't recommend you do an endoscopic translaminar, okay? But to do an endoscopic transforaminal at 5-1 is the best, but it takes tremendous skill, and you have to temper your goals of treatment to make sure that you do what's necessary to get the patient's symptoms gone, but not hurt the patient in the meantime. And that takes experience, a lot of experience, to know how far to push the limit, okay? It's like everything in life that's dangerous. If you push it past the limit, then the patient, somebody's going to suffer. If you try to climb Mount Everest when it's too cold or there's a blizzard at the top, and or you take the wrong path, then people can die. And with spine surgery, it's no different. We deal with life and death every day in spine surgery. All right? People can die from surgery. So you have to make sure you don't do things you shouldn't be doing. And over-treating a patient is something a lot of doctors do, especially inexperienced doctors. They think they know what they're doing, and they do too much, and they hurt the patient. Okay? For me, I want to do what's necessary to get rid of the symptoms for the patient. I want to get rid of her back pain. I want to get rid of her leg symptoms, and I don't want them coming back. So what do I got to do to achieve that? Well, I certainly don't have to take 100% of the herniation out. If I try to, I'll end up making her worse, just in the effort. Okay? All right, that looks pretty good. The nerve is right there. You guys see it on the left? It looks a little ratty. It's got some fat around it. And the reason it looks that way is she's had surgery here before. I didn't do it. Someone else did. And, it's a little beat up from that old surgery. There's some scar tissue on it. But all this is looking good. Let me have a grabber. Just about done. And then we're going to go to L4-5 next. Any questions?
Yes, we have a question from Samir on YouTube.
Okay, welcome to our stream.
They asked, I have an annular tear, L5-S1, really painful. Once you clean the annular tear in the surgery, there is a way for the disc to leak again because there is a tear. Will the pain come back?
Yeah, so Samir, when we do a debridement of your tear will heal itself. Right now your tear cannot heal because the nucleus is stuck, wedged into the tear. You see that right there?
Yes.
So, Luis, help me here. That's the herniation, right? So here's your annulus. You ripped it open. The nucleus is now stuck in there. The annulus can't heal. This is why you're having pain. I go in and clean it out with the laser, get rid of the herniation. I clean the edges so that they're nice and clean, and then they heal. The jelly will not come out as long as you do not do too much activity in the first year. So all of my patients are given restrictions. They know what to do, what not to do. And as long as you follow my instructions, you will not have a leakage through the tear that I fixed. It would require you to lift heavy weights or do contact sports, or bend over at your waist and pick things up repeatedly from the ground. If you do those things too soon, then you will have another herniation. And you'll have leakage, which is another herniation. But as long as you follow my instructions, you won't. How do I know this? Treating thousands of patients. That's how I know it. Practical experience. A lot of people think that what you think, but it's absolutely incorrect. Now, if you have a microdiscectomy or any other surgery besides this, Deuk laser disc repair, which is only available here in Florida, if you do any other type of surgery, then you can leak more because the other surgeons are not debriding the annular tear. I'm the only surgeon that does that in the world. So if there were 2 surgeons that did annular debridement with a laser, then there were 2 surgeons, patients that would not re-herniate. The problem is there's quite literally 100,000 spine surgeons worldwide, and of those 100,000, I'm the only one that doesn't laser annular debridement because I'm the one who pioneered it. And to date, in 2023, there's no other surgeons doing it. So their type of surgery leaves the tear open with nuclear material and scar tissue within that tear, which means that you're going to re-herniate again. So you have to choose the surgery and the surgeon properly. If you make a bad choice, then you're going to have a bad result, like most people. That's why we developed this new technique, because there was a need for an improvement. If the spine surgeries being done were fine and they were perfect and everyone was doing great, there would be no need for improvement. But because the results of spine surgery are so bad with the traditional treatments like microdiscectomy, fusion, artificial disc, laminectomy, and now with these newer treatments that are terrible like intercept, interspinous devices, mild procedures. There's lots of new treatments that are terrible. I need you to take pictures. Huh? So because there's such bad results with spine surgery, there's a need for improvement in the surgery. And that's what we have done at Deuk Spine. But the problem is we don't have venture capital money. We're not trying to sell a device. So there's no company that's profiting hugely off of these procedures, so they want to teach all the other surgeons how to do it so they can make money off their surgeries. There's no money to be made. We're not putting a metal implant. We're not putting bone graft, cadaver bone. We're not putting anything. Basically, we're repairing the disc. And because there's no implants, there's no money. Because there's no money, there's no promotion and marketing. The only one promoting it is me, and that's because I want people to get better without having horribly bad back surgery. All right, I'm advancing. I think that's good. Pull the dilator back a little bit. Let's see where we are. I've got the tube in. That looks good, right? Yeah. We're inside the tear. Now, compared to the last disc, this disc is better. It's healthier. Has a taller disc. It has a smaller tear. You're going to look and see in the scope, it's going to look very different. It's going to look healthier. It's too bad we don't have our blue dye, the Deuk Spine dye. By the way, you want to know what's fascinating? I was doing some research on indigo carmine, which is the dye we use. Obviously it's made in India. It's made in a few other countries, even South America. It's a plant that's grown. And the plant, look at all the red, by the way, guys. That's fascinating. Look at that. Can you guys see the pink color?
Yes, we can.
That's inflammation. You see, it should be white, not pink. And the reason it's pink is inflammation. So clearly this is an inflamed disc. By the way, most doctors would not be treating this disc because to them it looks too good to be painful, but it is painful. I figured that out and we just verified that with the discogram. It's an 8 out of 10 pain, same as the L4-S1. All right, so now we're using the laser to clean this tear. This is herniation right here, the white stuff. Less scar tissue, more herniation. This right here is scar tissue. See how it turns a golden color with the laser fiber, with the laser interacting with it? So that's laser energy hitting the tissue, and what it does is it turns calcium deposits gold. I've seen it in almost all my patients I've treated over the years, and I've been doing this 16 years. That golden color comes from basically the laser interacting with little bone spurs and calcium deposits called dystrophic calcification, which is only found in damaged discs. I mean, dystrophic calcification is found in other parts of your body, but you don't get dystrophic calcification in a disc unless the disc is damaged. So the only time you see that golden color with the laser on the disc is when the disc has been damaged and there's calcification of the disc. It's like not full calcification, but tiny little bodies of calcium. All right, questions?
Next question comes from Samir, once more on YouTube. And they said, I just got an MRI in India. Will I have to go through MRI again when I visit you for the surgery? I am from India and got no insurance in the US.
Samir, thanks for asking. It's a great question you're asking. We get that a lot. You do not have to get a new MRI in the United States. By the way, Deuk Spine Institute does MRIs very cheap, $200. We don't want our treatment to be unaffordable. We want to make it as affordable as possible. So our MRIs are $200 to $300 depending on what we're doing. And we try to make them very affordable. But if you've had an MRI done elsewhere, as long as the quality of the images are acceptable, and I could tell by looking at it what's wrong, then you do not need another MRI. And as long as your MRI is within a year and a half of the day of your surgery. So if you have a 10-year-old MRI, that won't work. I need a new one. But if you have an MRI that's within a year and a half, 18 months of your surgery, then you can use it. We don't need to repeat it. Our goal at Deuk Spine is to reduce the cost of care, not increase it. One of the ways we do that is by doing the right treatment the first time, so that people don't have to keep coming back getting more treatment. Now we can't do that in everybody, unfortunately. Some people end up leaving and they have some other kind of pain that they develop, and we have to treat that as well. It's not uncommon. About 25% of our Deuk laser disc repair patients also have facet joint pain, but they don't have it when they come to the clinic the first time. They have it later on when they get active, and we have to treat that in addition. Look at all these pieces of herniation popping out. I'm lasering them because it's very safe and effective way to do it, but you could also reach in there and grab them and pull them out with the grabber. It's just they're stuck down sometimes by scar tissue to the surrounding annulus, and they're hard to get out with the grabber, so I use the laser mostly because this is the debridement we talk about, the annular debridement. It's removing these herniated fragments that are stuck to the annular tear. They shouldn't be there. That's what's causing the inflammation. The pink stuff we saw earlier, remember? All right, we got 5 minutes and we're done. Now, our other two patients are doing well. The first patient we did today, she was a herniated disc in her neck above and below her fusion that she had done before. And she's already gone, right? She had no pain in her neck when I saw her before she left. Yeah, her neck was stiff, she said, but that's because she hasn't used it in years and because she had a fusion. But the pain that she had before surgery is gone. That's good. And then the thoracic patient that we did the DPR, he's still here, but he's going to be going soon, hopefully. Yeah, good. Yep. All right, if you have questions for me, type them up. You can see the herniation that was here is mostly gone, about 70%. And When you look at the MRI at L4-5, it didn't look that bad, but now that I'm in here, you can see all the scar tissue right here from the herniation and the inflammation that results. Look at all that. So this definitely needed to be fixed. She had 8 out of 10 pain here. She had 8 out of 10 pain at L5-S1 as well. I think she's going to be very happy. We also did a piriformis muscle injection. Dr. Patel came in and did that earlier because she has a torn piriformis muscle. So we're just addressing all the problems. And like I said, everybody's different, but the causes of pain are very much the same. We just have to identify which cause each patient has. All right, this is the outside of the disc right here. You guys see that? So we're just about done with the herniation. The laser fiber, by the way, is 1 millimeter wide, not like the cervical we did earlier, which was 0.5 millimeter. We used to do this procedure with a 0.5 millimeter wide laser many years ago. Right, Luis? And then we found out about the 1 millimeter, which is twice as wide, and we tried it out, and my God, it does a great job, and patients did very well, and it really cuts the time down quite a bit, right, Luis? Probably by at least 30% of doing the procedure, which is better for the patient. Less surgery time means safer for the patient. So we've adopted the thicker laser fiber for the lumbar, and we even do some of our thoracics with it as well. But it works very efficiently. It's very important in medicine to be efficient. And with efficiency, you don't compromise quality, you just shorten the time without taking away from quality. All right, well, if you have questions, type them up. I'm going to be done here in about a minute, and I will answer these questions for you face to face. But this is going very well. This is the L4-5 disc, and it was a lot worse in real life with the endoscope than it was on the MRI. Most doctors would have ignored it. We didn't. I could tell there was a tear. I could tell she had pain here, localized. And it's a good thing we did it, because if we didn't, she'd be coming back again for another surgery in the future. But now I think she's going to be very happy with the results of our treatment. All right, if you have questions, type them up. I'm going to come and answer them for you. But in the meantime, let's run our video as to how does the Deuk laser disc repair work.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay, we got a millimeter hole left in the disc that we've just cleaned up. Sorry, not millimeter, 3 millimeter. And that will close on its own. So earlier we had a question from one of our viewers about, hey, what happens with the hole that's there? It closes. But you could see it used to be a 7 millimeter hole, but now it's 3 millimeters. So we shrunk it down with the Deuk laser disc repair, and the patient has to do the rest. When we're done, those holes are almost always 3 millimeters. So we can't close the hole for them, but we get it started and we get it cleaned up so that it can close on its own. It's kind of like taking a thorn out of someone's skin, you know, a piece of wood that's stuck in there. Now they can heal their skin, but they couldn't do it without taking the thorn out. All right, everything went well. Let me show you the incision. Yep. So we lost about, I don't know, 5 drops of blood maybe. The whole surgery, it went very well. We did 2 discs with 1 incision. You ready, Henry?
Yes, sir.
Now let me just show you the incision here. You guys see this?
Yes, we do.
Let me bring a tape measure. Here. I made the incision a little big today. I made it about 8 millimeters or 9 millimeters. But there it is right there. So it's about 8 millimeters instead of 7. You guys see it? All right, Henry, let's take them to a testimonial. Meanwhile, they can type up their questions and I'll come answer them for you. Our patient is sleeping comfortably. We'll wake her up. She'll be out of here in about an hour, hour and a half. Good morning, I'm Dr. Deuk at the Deuk Spine Institute here in Melbourne, Florida, with one of my patients who traveled from California. He's been suffering with his lower back pain for years and found us on the internet and decided to come here and have the endoscopic Deuk laser disc repair. We performed that 12 hours ago, and here you are, ready to go back to California, it looks like. How do you feel?
I feel great. It took a long time to get to you. Surgery was quick and painless. I don't remember a thing. Your staff was wonderful, but I am pain-free.
That's awesome. Yeah, and you're going to stay pain-free. We don't have you on any pain meds. We don't have you on narcotics killing your pain. We didn't put any medicine in your back to stop your pain, so what you have is natural. And do you feel that pain anymore that you had before you came here?
No, the pain is completely gone. In fact, I quit taking my own pain pills 2 or 3 days before I got here. And I am on no pain pills at all, and I feel wonderful. When I woke up this morning, it was a different day, and I feel great.
And I feel wonderful for you for doing that. That's why we do what we do. We can cure pain, and we want everyone to know that, because nobody should have to live with pain every day. How does pain affect your life every day?
Pain is traumatic. The kind of back pain that I was suffering put me in bed. And for the last 3 months, I have been absolutely useless. Absolutely useless. And so I found you. It took me a few months to get here, and it was worth the trip.
It will be for the rest of your life.
Absolutely.
Worth the trip. Pain robs us of our dignity, doesn't it?
It does. It absolutely does.
And your parents are here, and they're very supportive. And that, to me, is so important, that you have people that understand what you're going through. I'm sure your parents have been a big support for you.
Oh, absolutely. Yeah, I was at work, a short story. I was at work last Wednesday dealing with this pain, and my back finally gave out to where I literally could not walk anymore. And I was 600 miles from home. And so I called my mother and father. They flew to San Diego and arranged the trip to get here. I called your place. I was scheduled for February 2nd, and I asked Richard on the phone if he could get me in sooner, because I was desperate. And you guys got me in a week or 2 sooner, got me in the 24th, which was yesterday. And so we made the arrangements, and I flew here, stayed in the hotel for a couple days, and was operated on yesterday. And yeah, it's well worth the trip. I apologize for getting emotional, but it's been a long trip to get here.
Well, we want you to get emotional, because it is an emotional thing. When you've been burdened with this pain for so long, and then suddenly it's gone, and you realize that life can be lived without that pain, you know, and that you can actually have a life without the pain.
Yeah.
So what are you going to do now that you don't have the back pain anymore?
Well, I'm going to get my life back together. I've got a new job, and they've saved it for me. My boss is wonderful, and I'm going to go back to work tomorrow, actually, if you can believe that.
Yeah.
And I'm going to start riding my bicycle again and getting healthy again.
Well, your surgery went very well. I don't know if you've watched it yet, but we were able to get in with a tiny 7 millimeter quarter-inch incision and fix both painful discs, and they were both very painful for you. And the pain was coming from a small tear that's located in the back of your disc where your herniation came out of. And that tear was just so inflamed, and we were able to clean out the herniation that was stuck in your tear and use the laser to debride it. And that's what the Deuk laser disc repair is. It's a debridement of the annular tear to eliminate back pain and leg symptoms. So we also have a cyst. We didn't treat your cyst. And do you think the cyst is causing any problems for you?
At this point, no. I don't think so, because all of my symptoms are gone. This morning when I woke up, I was a little nervous about getting out of bed. But that subsided quickly when I stood up and could stand up completely erect with no pain or bindage feeling in my.
And welcome. We've just finished our last surgery for today, and this is a young lady who has suffered for a long time with lower back pain. She had had a prior surgery done at L4-S1. It's called a microdiscectomy, and I try to keep people from having that surgery done. I used to do a lot of them. That was back before I knew there was a better way to do this. Most spine surgeons are trained to do microdiscectomies. The problem is it's a destructive surgery and it doesn't properly fix the herniated disc. And the reason for that is if you look at a herniated disc and what's happening, this being the disc here, if you do a microdiscectomy, you're grabbing out pieces of herniation from the back, but you're not doing anything to help the disc heal itself. Now, some doctors have come up with ideas, engineers, like the barricade device or disc seal. These are attempts by men to provide something, again, it's an implant so they can make a lot of money, to allow the discs to heal themselves. But they don't work. They never work. I've never seen them work. The best way to get your disc to heal itself is naturally, and that requires what's called a debridement. And how did I come up with this idea? Because it is my idea. So when I was a neurosurgery resident at the University of Florida in Gainesville, we had to rotate the first year. You call it internship. You have to rotate on different services. And I spent a month on plastic surgery, a month on cardiothoracic surgery, a month on orthopedic surgery. The list goes on. And anyway, 12 months, 12 rotations for a month each. So I got a pretty good, exposure a little bit to each of the different specialties of surgery. Well, in plastic surgery, in particular, the chairman was Dr. Eugene Caffey. Dr. Caffey, he was the chairman at University of Florida in Gainesville. This was back in the 90s. Amazing man, brilliant, sweet, kind, loved teaching, just generous, intelligent, just an incredible person. Anyway, one of the things I learned on the service was it's actually to treat something that nobody wants to treat. It's called a decubitus ulcer. And the thing about it is that people that are paralyzed can't move their bodies, so they lay in bed, they lay on their back all day, and what happens is the skin that they're laying on doesn't get enough circulation, so it dies. And they get this dead skin and dead muscle underneath because the spine is pushing on the bed, crushing the skin and muscle. They die, that area opens up, right? Or you get an ulcer from a patient who has not enough circulation in their legs, or diabetic, they don't have enough circulation. What happens is the wound cannot heal. So what we did, we went in and we did what's called a debridement. And that's where we would take the patient, take the ulcer, we would cut with a scalpel back to where there was good, clean tissue, viable tissue that had blood supply. All right, and we did that on both sides, and we basically dug out of the trench all this dead muscle and dead tissue. And scar tissue, inflammatory tissue, just got rid of it, cleaned it out. And what we were left with was this V shape in the body that then we applied a vac dressing, it sucked it closed, and then it healed. And then within about 3 to 6 months, my God, you look at it and you're like, was there a problem there before? And so what I learned was that when you have this scarred up, inflamed, dead tissue, and the body's trying to heal it, it won't. So I looked at the disc herniation. I said, you know what? It's more than just a piece of herniated disc sticking there hitting the nerve. There's a problem with the disc itself, with the outer wall. It can't heal. It needs a debridement. So I thought, how do I do this? And I brought the laser in and I started to clean that tear with the endoscope, because you can actually see it with the endoscope. That's the best way to do it. So we use an endoscopic surgery and use the laser to debride the tear. Bam, a new technology was born here at Deuk Spine Institute. And guess what? The disc started to heal, and the patients did not get reherniations. And so I've been trying to teach my fellow surgeons about it, but they already know everything. There's nothing new you can teach them. So I'm out here trying to teach people now, because I know that people want the best care for themselves, and they deserve it. They should get it. I want it for myself. I would want to get the best. So I want people to get the best. I want them to know what the best is. Because if your surgeon isn't going to give it to you, then you need to go out and get it for yourself. That's just the way it's going to be. And people deserve a right to know the truth. So that's why we do our broadcast. That's why we educate. That's why we teach. Because other doctors aren't going to do it for you. They want you to stay in pain. They want you to keep coming back and getting more shots. They want you to keep coming back and getting more surgery. And they make money every time you do. They're making money every single time. So back pain and neck pain has become this medical condition where people are exploited, for their problems. And I think it's wrong, because now we have the technology to cure back pain and neck pain. But it's available at Deuk Spine Institute. We're trying to spread and get the word out, and it's working, but it's very slow. It's very painful. And I won't spend money on social media to make it promoted. So we just provide these broadcasts for free. We do some YouTube and Facebook posts, but we want the word to spread organically, naturally, from the people who get better. They go out and spread the word, and it's working. It is working, but maybe by the time I'm 150, half the world will know about it. So it's a slow process. The dissemination of knowledge is very painfully slow. That's something I've learned in my adult life. I grew up as a kid in high school, and you're reading in high school history books about gunpowder, right? Oh, they discovered gunpowder. Wow, that was amazing. And you think, okay, well, they discovered it today. By next week, everybody in the world knows about it, right? But the reality is that's not how it works. And it didn't work that way back then. Probably took hundreds of years for the world to learn about gunpowder. And that seems like what it's taken for everyone to learn about this new technology. So we're trying to speed it up through these broadcasts. Anyway, surgery's done, went very well. We had no problems. Both discs were causing pain. She also had a torn muscle in her buttock, which we treated with a shot, which is the right treatment. Let's go to our questions.
This first one comes from Beth on YouTube.
Hi, Beth on YouTube. Thanks for watching and asking.
They ask, what is your opinion on multi-level cervical spine nerve ablation? I just had one from C2 through C5. Zero head pain anymore.
What is my opinion on multi-level cervical facet joint nerve ablation? I think it's wonderful. As you know, you just had it done and it worked. It sounds like you're not having any more pain. So I think it's the right thing to do in the right patient. If you have multi-level facet joint disease, so if you're having pain coming from your facet joints and you're having multiple facet joints causing pain, you need multiple levels treated. Unfortunately, the insurance companies don't want to pay for multiple levels. They want to pay for one level, which makes a lot of doctors just treat one level. But in my experience, when you have facet joint pain, it is always multi-level. It's always 2 or 3 or 4 facets. And the surgery we did earlier today, that patient had 5 facets, that's multi-level 5, on each side. So we did 10 facet joint burning of the nerves today with the Deuk plasma rhizotomy. The difference is our treatment is permanent. What you had is temporary. Your pain will come back, unfortunately. But you can come to Deuk Spine and get the Deuk plasma rhizotomy. But I'm a big believer in treating the patient properly with one treatment the first time.
Next question comes from, excuse me, from Miran on Facebook, and they ask, "Hello, doctor. How do you diagnose a torn piriformis? Is it through through MRI?"
Hello, Miran on Facebook. Good to hear from you again. Thanks for joining us. The piriformis muscle runs in your buttock, okay? And if you look here at the spine, the hip joint is right there, and the femur comes out here. The piriformis muscle runs literally from the sacrum, which is right there, over to the top of the hip joint, to the top of the femur, okay? It's a muscle that runs here. So on the exam, well, first of all, when people come in and they have pain in their buttock, like literally 90% of the time, it's the piriformis. So just probability, natural probability tells me that if they're having buttock pain, it's the piriformis, right? The way I verify that is by physical exam. You touch the top of the buttock right in the middle of the butt cheek. If this is the butt crack, where the middle of the sacrum is, and this is the hip, the side of the hip, it's literally right between, exactly dead center. And if you push on that spot with your fingers, it will be sore. It'll hurt. That's a piriformis. You don't need an MRI to diagnose piriformis syndrome. You don't need a CAT scan. You don't need any diagnostic test. It is a clinical diagnosis. It's made clinically by the physical exam. That's why I keep telling people, MRIs don't tell you where pain comes from. Patients do. And you have to pay attention to the physical exam. Unfortunately, most spine doctors don't do a physical exam. They just look at an MRI.
Next question comes from Best Sports Media TV on YouTube, and they ask, when finished surgery, are antibiotics required to prevent infection?
Best Sports Media on YouTube. Thanks for being here and thanks for asking. You're asking about antibiotics. So when we're done with surgery, are antibiotics necessary after surgery? Absolutely not. Not with the Deuk laser disc repair. As a matter of fact, not with any normal, clean spine surgery. You don't need antibiotics afterwards. Even though you put metal in the patient, you still don't need antibiotics. So what we do, and what's the right thing to do, is to give a dose of antibiotics during surgery, right? Within an hour of incision, either before or after. Within an hour of incision. And some patients can't have antibiotics because they're allergic to antibiotics, so we can't give them antibiotics. And the risk of having a bad reaction from them is too high. If you have an allergic reaction to an antibiotic, you can go into anaphylactic shock. So we don't give it to people who have a lot of antibiotic allergies. We won't give them their preoperative antibiotic dose. And we'll just document that they have a high risk for complication. But the vast majority of patients will get the antibiotic. We give 2 grams of Kefsol, which is I want to say it's been a while. I want to say it's a first generation cephalosporin, but it could be a third. We give it IV, and they get that during surgery. We also use betadine, which you saw was the brown stuff that I put in at the end. That will kill any kind of bacteria. So we do definitely take infection seriously, or the risk of infection seriously, and we have several strategies or countermeasures that we've deployed on each patient, including sterile prep and drape, including the Ioband, DuraPrep, IV antibiotics, alcohol wipe, and then of course the iodine, betadine, developed by NASA. So we do a lot of stuff, plus we put a bandage, sterile bandage, etc., to prevent infection. But you do not need post-operative antibiotics.
Next question comes from Danette on Facebook.
Hello, Danette on Facebook.
And just reading from the beginning. Hi, doctor. I'll be downloading my MRI and praying that I can be seen or have a consultation with you. I heard all great things from a patient you've seen and did surgery on. I will fly to Florida and been suffering for 11 years now. I had a dissectomy surgery on my L4-S1 with an orthopedic surgeon in November. Then my symptoms are coming back with numbness, buttocks pain, right inner thigh pain, cramping, and weakness in both legs now. It is now going down to my feet, having burning and pain. I have an EMG Thursday and Friday, and then I see the doctor in Loma Linda. That's the neurosurgeon, July 3rd. Will the EMG help define what's going on with me?
Yes.
I live in Riverside, California.
Yes, hi Danette, you're from Riverside, California. I used to go to UC San Diego. I'm very familiar with Riverside. And I believe I know maybe one of the patients. We've had several from California, and they're very happy, obviously, with the results. Yes, we can definitely help you, and it starts with the MRI and the nerve test and doing a telemedicine consult with Zoom. It'll take us 10 minutes to figure out what's wrong. I will be able to tell you exactly what needs to be done. And my fear is that your doctor in California is going to tell you need a fusion. You don't need a fusion. I promise you, it's totally unnecessary. We can fix you without fusion. So I look forward to helping you. I look forward to our meeting. You're going to be fine. We will figure it out, and we will give you good advice.
I don't believe this is a question, but I'll just say it anyways. This is from Mirren on Facebook, and she said, I have now my MRI available. Both images and report is on portal. All I need to provide is a username and password, and you can access Hope. This is an option on the Deuk Spine form. Okay.
Hi Mirren, it is an option on the Deuk Spine form. So there's 3 ways to get your MRI to us, and people use all 3 ways. When you fill out the form for the free MRI review, it's going to give you a choice to either drag and drop your image files over from your CD or zip drive onto our portal hole, and that goes straight into our Google Drive, or you can mail us by mail, like UPS, FedEx mail, not email, but UPS, FedEx, etc. You can mail us a CD or zip drive of your file, of your MRI images, or you can send us your portal login credentials and link, and we will do it that way. So we use all 3 ways. Everybody likes different things, but I look forward to getting your MRI and the report and helping you.
And that is it.
Okay, great. Well, thanks so much, Henry. Welcome back.
Thank you.
It's been a few weeks since we've been operating and a few weeks since we've been broadcasting.
Yeah.
It's good to hear some of the old people that were around prior to my trip, and it's great to hear from the new people as well. And we broadcast all of our surgeries live every week. We have 5 surgeries for Thursday this week, and we are getting busy with surgeries. We have a lot of patients. And what surprises me is most of these people are coming from other states and other countries, and they're getting their telemedicine done through Zoom, just like through the free MRI review. So we're completely changing the way healthcare is being delivered. In particular, we're changing the way spine surgery and spine care is being delivered at Deuk Spine Institute by using virtual consultations and diagnosing things virtually without the patient actually being here. That is truly cutting edge stuff. So thanks for joining us. Have a great night and rest up. We'll see you on Thursday. Bring some popcorn and lots of soda.